I am very excited to introduce Dr. Corser, who attended medical school at Upstate Medical Center in Syracuse in New York. He completed his training in internal medicine, followed by a chief medical residency and fellowship in pulmonary and critical care medicine at the University of Cincinnati. He's been involved in sleep medicine since 1989 and is now president of the Sleep Management Institute and Intrepid Research in Cincinnati. Dr. Corser has been involved as an investigator in hundreds of clinical trials in a variety of different indications, but with a focus on disorders of hypersomnia. He is currently participating in numerous trials with pharmaceutical companies developing novel therapies for narcolepsy and idiopathic hypersomnia. And today he's going to bring all of us up to speed on the latest research and advancements in IH. And we're really grateful for you, Dr. Corser, giving up your time. Again, please, everyone, put questions in the Q&A, and we will address those at the end. But for now, I'm going to hand over to you, Dr. Corser. Thank you.
Great. So the focus of today's talk will be on the therapeutic treatment of idiopathic hypersomnia. Let's see, do you have the slides up?
Yeah, we've just got our social media team working on the back end here to get those onto the shareable platform. And you're joining us from Ohio, is that right?
Cincinnati, yes. So right now there's in brief, there's half a dozen pharmaceutical companies developing orexin agonists, and we'll talk about that during the course of this presentation. That's one of the most exciting things
It is.
Currently available. So,
Yeah, we're excited.
So we'll talk a little bit about the idiopathic hypersomnia, the diagnosis, the prevalence, and we'll also talk about treatment options. So next slide.
All right, wonderful. Thank you.
So let's define idiopathic hypersomnia and its clinical features, review the diagnostic approach and differential diagnosis. Then we'll summarize the current pharmacologic treatment as well as the future pharmacologic treatment for IH, and then we'll provide practical tips for treatment selection and monitoring. Next slide. So what is idiopathic hypersomnia? It's really a diagnosis of exclusion. It's a chronic sleep disorder characterized by excessive daytime sleepiness despite adequate or prolonged sleep time. And the most common symptoms, in addition to excessive sleepiness, are sleep inertia and brain fog. Probably 80 or 85% of people with idiopathic hypersomnia have this brain fog. So most people with idiopathic hypersomnia sleep a normal amount through the day, but probably about 20% are long sleepers, and this is probably a different phenotype. In other words, a different cohort of people that sleep for 11 hours or more per day, but still feel unrefreshed. So these are the so-called long sleepers. It's unlike narcolepsy in that there are no cataplexy episodes. And the diagnosis is based on sleep studies and then excluding other potential causes of excessive daytime sleepiness. And that's really important. You have to exclude a lot of other things to arrive at the diagnosis of idiopathic hypersomnia. So usually this is a diagnosis that is made by not only the history, taking a history from the patient, but also doing an overnight polysomnogram. And that's mostly to exclude other disorders such as sleep apnea, periodic limb movement disorder, or some other sleep disorder that is disrupting sleep. Then the following day, a multiple sleep latency test is conducted. This is a series of naps throughout the day that quantitates or measures the tendency for people to fall asleep. So a short sleep latency of less than 8 minutes is required for the diagnosis. And then narcolepsy has REM onsets on 2 or more of these nap opportunities. So if we don't see any REM during these naps, or if we only see one REM period, then that's consistent with the diagnosis of idiopathic hypersomnia. As we mentioned, there's another subset of patients that are long sleepers that sleep more than 11 hours per 24-hour day. And that includes not only the nighttime sleep, but also napping throughout the day. And if you can, we want to capture this objectively with actigraphy, usually in association with a sleep log. So if we document that people sleep for 11 hours or more per day over the course of 7 day, 1 week, then that is indicative of idiopathic hypersomnia with so-called long sleep time. So, and typically we want to see these symptoms lasting for at least 3 months with no other medical or psychiatric explanation. Sometimes people with depression can manifest as having excessive sleepiness or long sleep time, but usually we can determine that based on the history and the objective testing. These people with depression associated with excessive sleepiness typically don't have the characteristic findings on the overnight polysomnogram or the MSLT. Next slide. So how common is idiopathic hypersomnia? It used to be considered a very rare disease, but if we look at the current diagnostic criteria, about 1.5% of the general working population would meet the diagnostic criteria for having idiopathic hypersomnia. So it's probably much more common than was originally thought. Uh, the long sleepers are probably much less common as compared to the people that are normal sleepers with excessive sleepiness. The prevalence may vary slightly across regions due to differences in recognition and diagnosis, and it is diagnosed differently in Europe. They use more apt to use 24-hour polysomnography and actigraphy in their diagnostic approach. So it's in comparison with narcolepsy, about 1 in 2,000 people in the United States have narcolepsy. So idiopathic hypersomnia, based on the current criteria that we use for diagnosis, may be more common than narcolepsy. And many patients, as you know, are misdiagnosed with depression, chronic fatigue syndrome, or some other syndrome as compared with idiopathic hypersomnia. So it is a considerable journey between the onset of symptoms and when people are actually diagnosed. Idiopathic hypersomnia usually begins in late teens or early 20s, but can occur at most any age. There's a slight female predominance. There's been no confirmed genetic or environmental risk factors, and there may be a family history of sleepiness in some cases. Next slide. So, idiopathic hypersomnia tends to be a chronic and maybe a lifelong disorder, although severity may fluctuate. And the symptoms of excessive sleepiness may fluctuate over time, and some individuals may experience periods of improvement or even remission, but other patients have persistent symptoms despite treatment. Next slide. So there's been some studies that have evaluated idiopathic hypersomnia patients over extended periods of time. There was a European study published that showed that there was remission or change in the diagnosis in around 20% of people that were followed over the course of a decade. In some cases, people may have resolution of their symptoms, or in some cases, they may develop some other condition that would preclude the diagnosis of idiopathic hypersomnia. So there it is different from narcolepsy in that respect. People with narcolepsy typically don't have remission of symptoms over time, but people with idiopathic hypersomnia may have improvement or even remission of symptoms over the course of a decade or more. And there is diagnostic uncertainty. There's, these, we don't have a definitive biomarker. The best we can do is the sleep study as well as the MSLT. So there isn't any definitive biomarker. There have been many tests that have looked at, is there changes in the cerebral spinal fluid and the neurotransmitters in these people with idiopathic hypersomnia, and thus far nothing definitive has been found. So there's really no easy biomarker or test other than the sleep testing and the MSLT to make a diagnosis. So there is some diagnostic uncertainty. And as you may know, there's very substantial overlap between type 2 narcolepsy and idiopathic hypersomnia. The people with the long sleep type may be a different phenotype or subset of idiopathic hypersomnia, but there's a substantial overlap between type 2 narcolepsy and idiopathic hypersomnia. And if you do retest testing on people with idiopathic hypersomnia, only about 30% of people will have concordance between the first test and the second test. So there is this diagnostic uncertainty and overlap with type 2 narcolepsy. A substantial number of patients will see improvement with medication, but there's probably 25 to 30% of people that really don't respond very well to any sort of medical therapy. Next slide. So this disorder is associated with profound impacts on quality of life, but has not been associated with an increase in mortality. But it certainly can impair work, school, and relationships or performance, in social contexts or in the work context. And brain fog can be extremely troublesome for people with idiopathic hypersomnia. Also, poor memory, slowed thinking is very common. Many people report difficulty maintaining employment because of this overwhelming fatigue and because of the brain fog. And support groups may be helpful. Quality of life is certainly dramatically impaired with people with idiopathic hypersomnia. Next slide. So as we know, it's often misdiagnosed or underdiagnosed. There's very high healthcare utilization with idiopathic hypersomnia. And excessive sleepiness is often not recognized by public or healthcare professionals. People with excessive sleepiness may be labeled as lazy or not motivated, but we know that is not the case. And to give you some context, about one-third of patients or adults in America sleep for less than 6 hours nightly, and often this contributes to sleep deprivation, which can manifest as excessive sleepiness. Conversely, about 8% of adults in this country sleep on average 9 hours or more nightly. So it's important to take a history of people. Now, people with idiopathic hypersomnia can be differentiated from the people that are sleep deprived, because if people that are sleep deprived sleep an adequate amount of time, that is, if they get consistently the amount of sleep that their body needs and they feel awake and alert during the day, and this is in contrast to people with idiopathic hypersomnia who feel exhausted throughout the day, no matter how much sleep they obtain. Next slide. So, treatment principles first, we want to address reversible causes. Certainly, if there's some underlying sleep apnea or depression, we want to treat that. There's very limited benefit from behavioral therapy, and pharmacologic therapy has been the mainstay. And the goals are to improve alertness, reduce sleep inertia, and overall improve quality of life. Next slide. So to understand the pharmacologic treatment for idiopathic hypersomnia, first off, we have to understand the neurotransmitters. These are proteins or peptides in the brain that affect wakefulness. So there's half a dozen of these neurotransmitters. There's acetylcholine, dopamine, histamine, norepinephrine, orexin, and lastly, serotonin. All of these neurochemicals can promote wakefulness. Next slide. So orexin is sort of the master neurochemical in the brain that stabilizes sleep and wake, and it interacts with all the other receptors or other neurotransmitters in the brain that help promote wakefulness. And so the average human brain contains about 86 billion neurons, and there's only about 50 to 80,000 neurons in the brain that actually produce orexin. And all these neurons are located in the lateral hypothalamus, an area of the brain. So this is a very uh, very potent molecule that promotes wakefulness. Next slide. So the other neurotransmitters that are very important in promoting wakefulness and decreasing daytime sleepiness is there's dopamine. And dopamine not only promotes wakefulness, but it's also involved in learning, motivation, reward, and movement. And then there's also norepinephrine, and this is thought to be important not only in helping people remain awake, but also it's important in arousal, attention, cognition, and task performance. And norepinephrine neurotransmission is very high during wakefulness and high vigilance states, and pretty much minimal during sleep, especially slow wave sleep. So these are very important neurotransmitters and are involved in allowing us to stay awake and concentrate during the day. Next slide. So these are the currently available FDA-approved medications for treatment of narcolepsy. And as we'll talk about, there's only one medicine currently approved for treatment of idiopathic hypersomnia. But for narcolepsy, there's the GABA B agonists, and these are the so-called oxybate therapies. There's sodium oxybate, which is Xyrem, that was first approved in 2002. There's lower sodium oxybate called Xywav. And then there's an extended release sodium oxybate called Lumryz, and this is made by a company called Avadel. So these medications are really very helpful in allowing people to stay awake during the day. So they're wake promoting agents, but they also decrease cataplexy in narcolepsy. Then there's pitolisant. This is also known as Wakix. It's made by a company called Harmony. And this increases histamine in the synapses in the brain. And histamine is another important neurotransmitter that allows us to stay awake through the day. And this is very effective for treatment of cataplexy as well as excessive sleepiness. Then there's the dopamine reuptake inhibitors. So by that, we mean that this allows dopamine to stay in the synapses longer, thereby promoting wakefulness. Modafinil was first introduced around 1998 in this country, was first approved. The only difference between modafinil and armodafinil is armodafinil has a longer duration of effect, but is very similar to modafinil in terms of the adverse effect profile. And these medications are indicated for promoting wakefulness in people with excessive sleepiness. And currently, these medications are indicated for narcolepsy, obstructive sleep apnea, as well as shift work sleep disorder. Then there's the norepinephrine dopamine reuptake inhibitor, solriamfetol. This is also known as Sunosi. This is made by a company called Axsome, and it's indicated to help people remain awake during the day with excessive sleepiness. It does not treat cataplexy, but this medicine has a longer duration of effect as compared with modafinil or armodafinil. And then lastly, there are the stimulants, the amphetamines, and then the methylphenidate. Best known amphetamine is Adderall, and then methylphenidate is well known as Ritalin. And these medications cause release of norepinephrine and dopamine into the synapses, so they cause this huge release. They also inhibit reuptake of these neurotransmitters, dopamine as well as norepinephrine. So they're very powerful in terms of promoting wakefulness. So the recommended pharmacologic options for treatment of narcolepsy, this is by an American Academy of Sleep Medicine, the strong recommendation for modafinil, pitolisant, sodium oxybate, and solriamfetol. And then this is before the advent of the lower sodium oxybate or the extended release sodium oxybate. And then conditional recommendations are for armodafinil and then the stimulants dextroamphetamine and methylphenidate. So next slide. So these are the emerging therapies for type 1 narcolepsy, but these orexin agonists are all being also evaluated for idiopathic hypersomnia. So there's currently 6 companies developing these orexin agonists. Takeda is going to be the first to have their medication approved, and the first one approved is so-called TAK 861 or oveporexton. And this, they have very good data that I'll show you. They just presented their data for type 1 narcolepsy in Singapore in September. And so they've got very strong data that this is remarkably effective at improving wakefulness for people with type 1 narcolepsy. They expect submission to the FDA before the end of this year and then potential approval the first part of next year. There's Alchemies. They also have a very good-looking orexin agonist. And then there's Centessa, which has ORX 750. Eisai is also developing a drug, orexin agonist, and Harmony's orexin agonist is BP1-15205. And then lastly, Jazz also has a orexin agonist that's in early phase testing. So there's a drug called Mazindal. This is a triple monoamine reuptake inhibitor. It affects dopamine, norepinephrine, as well as serotonin, and it also has partial orexin 2 agonist properties. This drug was used in Europe over the course of a decade and was shown to be very effective for treatment of narcolepsy as well as idiopathic hypersomnia. Unfortunately, there's intellectual property disputes and patent disputes with this medication. So, unfortunately, even though has shown very good efficacy, it may never see the light of day because of these legal issues. Then there's a selective norepinephrine reuptake inhibitor. This is made by Axsome. It's called reboxetine, and they've shown very good effectiveness for treatment of cataplexy, but it also has wake promoting properties. So I expect submission to the FDA in the near future and possible approval sometime next year. And lastly, there's the H3 antagonist inverse agonist. This is pitolisant, otherwise known as Wakix. This is made by the company Harmony, and they're developing a high dose formulation. Currently the highest dose is 35.6 milligrams, and they're developing a high dose formulation that looks promising for treatment of narcolepsy, and they will be testing it for idiopathic hypersomnia. Next slide. So how does orexin work? So orexin is released by these neurons in the lateral hypothalamus. Again, there's only 50 to 80,000 of these neurons. And the pathophysiology of type 1 narcolepsy is that these neurons have been destroyed, probably by an autoimmune mechanism that may be triggered by an infection of some sort, like a strep infection or a viral infection. So this infection may trigger an autoimmune response that destroys these orexin-producing cells, and that's the pathophysiology of type 1 narcolepsy. They have a deficiency of orexin in the brain. And that contrasts with type 2 narcolepsy and idiopathic hypersomnia, whereby people have normal levels of orexin. So these orexin neurons produce this what's called preproorexin, which is cleaved or divided into orexin A and orexin B. So there's two distinct molecules of orexin, and both of these bind to the orexin 2 receptor. And orexin 2 receptor is thought to be the major receptor that stabilizes wakefulness and regulates REM sleep. The orexin 1 receptor has completely different properties, and that's more related to metabolism and reward-seeking behavior. But the orexin 2 receptor stabilizes wakefulness and regulates REM sleep. Next slide. So all these companies are focusing on these peptides that bind specifically to the orexin 2 receptor to stimulate wakefulness. This is the data from Takeda. So their drug for type 1 narcolepsy is called TAK 861 or oveporexton. And this is data that was presented in Singapore a couple months ago. So all of these orexin agonists have shown remarkable effectiveness in people with type 1 narcolepsy because these people are all missing orexin in their brain. So if you replace the effect of orexin in the brain, people have this dramatic effect. So all of these drugs show incredible effectiveness for type 1 narcolepsy. Now, people with type 2 narcolepsy and idiopathic hypersomnia are going to require substantially higher doses as compared with type 1 narcolepsy. So typically, the dose for type 2 narcolepsy as well as idiopathic hypersomnia is about 4 times higher as compared with type 1 narcolepsy. So the type 1 narcoleptics are very sensitive to this. The people with the type 2 narcolepsy and idiopathic hypersomnia will require higher doses. All of these orexin agonists have similar adverse effect profiles. When people are first exposed to this, they may develop insomnia. It really lights up the brain, and it's people may have insomnia that typically dissipates within a week or two, but it can cause transient insomnia. The other very common side effect that we see is frequent urination. So these molecules, these orexin agonists, stimulate this area in the brain that it causes frequent urination. So we see this intense urge to urinate and very frequent urination that usually does dissipate within the course of a week or two. But this is a very common adverse effect seen with all of these orexin 2 agonists. But the efficacy is remarkable, especially in type 1 narcolepsy. I don't have any data to show you for IH or type 2 narcolepsy at this point, but I will be able to share that with you within the next, certainly within the course of the next year. Next slide. So I showed you some of Takeda's data. This is the data from the Alchemies, which their product is Alixorexton. So they've got very strong data as well, especially in type 2. It shows their compound shows not only a pronounced effect in terms of promoting wakefulness, but it also has cognitive effects in terms of improving cognitive function. This is measured on the British Columbia Cognitive uh, uh, British Columbia Cognitive Complaint Inventory. They've also got very strong objective data on the maintenance of wakefulness testing and other subjective data. So they've got a very promising compound. They're again studying this not only for type 1 narcolepsy, but also for type 2 narcolepsy as well as idiopathic hypersomnia. Centessa is not far behind Alchemies. They've got a very promising compound as well. They're looking at this for type 1, type 2, as well as idiopathic hypersomnia. And Eisai also presented some very strong data showing that their compound dramatically improves the maintenance of wakefulness, sleep latency, and they compared their drug to modafinil, and they showed that at doses of 10 and 25 milligrams, their compound showed better effectiveness at producing alertness as compared to modafinil. So all of these orexin agonists are currently in the pipeline, along with a couple others. Next slide. So historically, off-label medications that have been used are modafinil and armodafinil. As we mentioned, these are dopamine reuptake inhibitors. Then there's the stimulants, which cause neuronal release of and reuptake inhibition of dopamine and norepinephrine. So these are very potent agents. Bupropion has also been used off-label. This is a norepinephrine and dopamine reuptake inhibitor. Uh, so, atomoxetine has also been used. That's the otherwise known as Strattera. That's a drug for uh, attention deficit disorder, but that's a norepinephrine reuptake inhibitor. And then lastly, the oxybates look very promising for treatment of idiopathic hypersomnia. Currently, Xywav is the only medication indicated for treatment of idiopathic hypersomnia. This is the low sodium oxybate. It's dosed twice nightly. It shows remarkable efficacy. But notably, in their trial, there was about 75% of people with idiopathic hypersomnia responded to Xywav. 25% did not respond well to Xywav. So the trial that was conducted was an enriched trial. Only the 75% of people that responded to it were allowed to participate throughout the duration of the trial. Next slide. So as we mentioned, the Xywav is the only currently approved treatment for idiopathic hypersomnia that was approved in 2021. And as we mentioned, only about 75% of people were responders, but those that were responders showed a dramatic improvement in their ability to stay awake. The typical dose, somewhere we use typically between 6 and 9 grams. That's the usual therapeutic dose for most patients. Xyrem, which is the high sodium version of oxybate, contains 1,640 milligrams of sodium. Xywav contains 92% less sodium as compared with Xyrem. That's the major advantage. So these medications, these oxybates, they consolidate nocturnal sleep. They cause an increase in deep sleep by about 40%. Really consolidates nocturnal sleep, but it's very effective treatment for sleep inertia. And also, these medicines dramatically improve wakefulness during the day. There's like a 10-point decrease in the Epworth Sleepiness Scale, which is quite remarkable and very effective as compared to placebos. So they're very effective. I found them very effective to help people awaken in the morning. So those people with sleep inertia may benefit from this. There is a REMS program. This is called the Risk Evaluation Mitigation Strategy Program. So there's prescribers have to enroll in this program, and then this medication is carefully regulated because of potential for abuse. Next slide. So, as we mentioned, this Xywav improves excessive sleepiness and daytime functioning. This is a very short-acting medication, so typically one dose is administered at bedtime and a second dose between 2.5 and 4 hours later, and the usual therapeutic dose is 6 to 9 grams. Most common adverse effects include nausea, dizziness, and potentially respiratory depression at higher doses. Next slide. So there's the Lumryz. This is the extended release oxybate produced by the company Avadel. They are conducting a phase 3 clinical trial for idiopathic hypersomnia that is nearing conclusion. So this hopefully they will have a conclusion of their trial here in the near future, and they will be able to submit to the FDA for approval for idiopathic hypersomnia, hopefully next year. Their dosing is similar to Xywav. The typical dosage range is between 6 and 9 grams per night, and this is just administered once nightly at bedtime. So there's no reason to administer it twice nightly, just once nightly. And as you may or may not have heard, Avadel was just very recently acquired by Alkermes, so that's going to be interesting. Alkermes, as you know, is developing the orexin agonist, so they wanted to get into the sleep space, and thereby they acquired Avadel. So the sodium content of Lumryz is very similar to the Xyrem, that is 1,640 milligrams of sodium for 9-gram dose of Lumryz. In Singapore, Avadel announced that they have acquired a no sodium extended release oxybate product that they will be testing. So that's very exciting. That's going to be on the horizon. So no sodium extended release oxybate, once night oxybate. Next slide. So Sunosi has also been used off-label as treatment for idiopathic hypersomnia. This is a dopamine norepinephrine reuptake inhibitor. It's currently approved for excessive sleepiness associated with obstructive sleep apnea as well as narcolepsy, but there's growing evidence that it may be beneficial for idiopathic hypersomnia. The usual dose is between 75 and 150 milligrams. It's dosed once daily. It typically has a longer duration of effect as compared to modafinil and armodafinil, and the adverse effects include anxiety, headache, or in some cases it can cause a modest increase in heart rate or blood pressure. So this also looks promising. So this is the mechanism of action of Sunosi. So by inhibiting the reuptake of dopamine and norepinephrine, it causes an increase in these neurochemicals in the synapses, thereby promoting wakefulness. Next slide. So Sunosi has been extensively studied, and it has been shown to improve wakefulness throughout the course of over the course of 6 months and even longer. It's been tested in people with narcolepsy as well as narcolepsy as well as obstructive sleep apnea. And you'll see improvement beginning the first day. Typically, the duration of effect is 9 hours or longer. It really is not metabolized. It's excreted unchanged in the urine, so it really doesn't interact with other medications, which is a very big plus for Sunosi. So if you look at modafinil and Wakix, or pitolisant, all of those things can decrease the efficacy of birth control, and they potentially could interact with other medications because they're metabolized in the liver. So Sunosi doesn't have any interactions like that, so that gives it somewhat of an advantage in that respect. And it's generally well tolerated. Only 3% of people discontinued Sunosi due to adverse effects compared to 1% for placebo. Next slide. So then there's pitolisant. This increases histamine in the synapses. Uh, they uh, they looked at idiopathic hypersomnia, and there was a big trial that was conducted, a phase 3 study. Unfortunately, because of the design of the study, they didn't achieve their endpoint, which was a reduction in the Epworth Sleepiness Scale. So it was not approved by the FDA, but certainly it does show efficacy for a number of people. And as I mentioned, the company Harmony is developing a high dose formulation of Wakix, and that's going to be tested here beginning next year. And the higher dose formulation is going to be tested in patients with idiopathic hypersomnia. So there is hope that eventually pitolisant will be approved for idiopathic hypersomnia. So they've got an enhanced version that is much yeah, higher doses. So as I mentioned, the highest dose currently is 35.6 milligrams. They're looking at doses probably about twice that uh, for treatment both of narcolepsy and idiopathic hypersomnia. Next slide. So histamine also plays an important role in promoting and stabilizing wakefulness. So orexin interacts with histamine to, and these both these neurochemicals interact with other wake-promoting neurochemicals to stabilize wakefulness. So they inhibit sleep-promoting neurons as well as stimulate wake-promoting neurons. Next slide. So Wakix basically acts in a couple different ways to increase histamine in the synapse. It increases synthesis of histamine in the neurons, as well as prohibiting the reuptake of histamine. So that the net result is an increase in histamine and a longer duration of histamine in the synapses, and this would allows people to stay awake better. It also is remarkably effective for treatment of cataplexy. And the big thing about this is that it's non-scheduled. It's the only non-scheduled wake-promoting medication currently available because it doesn't affect norepinephrine or dopamine. It just specifically affects histamine. Next slide. So as I mentioned, this is it's not a controlled substance. It's the first and only FDA-approved non-scheduled treatment for patients with narcolepsy. Next slide. So other agents that are used off-label, modafinil is often used first line. Stimulants are effective, but they potentially could increase cardiovascular risk over time, and they do have some abuse potential. And then there's various antidepressants which have shown some limited benefit, like bupropion. Next slide. So the treatment algorithm, first, we want to confirm the diagnosis and rule out other causes of excessive sleepiness, such as circadian rhythm disorder, obstructive sleep apnea, or some other sleep disorder like periodic limb movements. If patients present with predominantly excessive sleepiness as the major complaint, modafinil followed by solriamfetol or stimulants are commonly used. For sleep inertia, Xywav is remarkably effective. It's very effective to promote wakefulness as well as allow people to wake up better in the morning. And for refractory patients, people that don't respond well, pitolisant or combination therapy may be useful. Next slide. So whenever we prescribe stimulants, solriamfetol or modafinil for that matter, we want to obtain a baseline assessment of cardiovascular risk and assess whether these medicines are appropriate for people that have increased risk for cardiovascular disease. We also want to make sure the blood pressure is well controlled before we initiate medications like this. There's REM education that has to be initiated when we prescribe oxybate, so we uh, give people literature regarding the potential benefits and adverse effects associated with oxybate therapy. So that's important. Plus, patients have to register with this REMS program. And then throughout treatment, we want to monitor for potential abuse, mood changes, and blood pressure. And of course, we always look for drug interactions, especially with modafinil, armodafinil, and pitolisant. Next slide. So the emerging therapies, there's these companies that I've mentioned, Takeda, Alchemy, Centessa, Jazz, Eisai, and Harmony are all developing orexin agonists. The most advanced candidates will be Takeda 861 or oveporexton. That's probably going to be approved sometime early next year for type 1 narcolepsy. For type 2 narcolepsy, Takeda has a different compound that's TAC 360. So this is going to be used for treatment of NT2 as well as IH. And then Alchemies, they're looking at the type 1, type 2, as well as IH for their compound. And then Centessa is also investigating type 1, type 2, as well as IH for their orexin agonists. So the data looks promising for idiopathic hypersomnia and narcolepsy. We'll have to see how all this plays out, but uh, the early data and from my personal experience, a lot of these compounds look promising for idiopathic hypersomnia. Next slide. Other pipeline agents, Axsome is developing reboxetine. That will be submitted to the FDA for treatment of cataplexy, but it also promotes wakefulness. As we've mentioned, Avadel has the once nightly Lumryz, which is being tested for IH as we speak. And their trial will be concluded shortly. And then they just acquired this once nightly salt-free preparation for narcolepsy, but they'll eventually also be testing it for idiopathic hypersomnia. And this is virtually no sodium and once nightly. And then, as we mentioned, high-dose pitolisant or Wakix, they're investigating this, an enhanced formulation that will decrease any gastric side effects and a higher dose formulation. Next slide. So takeaways, idiopathic hypersomnia is disabling, but increasingly treatable, and we'll have a menu of different medications available to treat idiopathic hypersomnia as well as other disorders of central hypersomnia. Low sodium oxybate is the first and only approved treatment. Solriamfetol and pitolisant, which are Sunosi and Wakix, may be effective for some patients. Orexin agonists are going to transform management of the disorders of hypersomnia. And personalized therapy will often involve a combination of different medications to address the symptoms associated with idiopathic hypersomnia. So with that, I will conclude and open up to any questions.
Thank you. That's so informative. And I think, you know, a lot of the depth there does speak to, as you said in the last slide, how it is very disabling living with IH and narcolepsy, but increasingly treatable. I think that's a great takeaway. I think we've got a couple of minutes for questions. So I'm just going to read from the chat. And again, thank you for that, because we've got a lot of people with a lot of questions here. But first of all, are there any theories around why there seems to be a higher prevalence of IH among women?
There may be a slightly higher predominance of IH in women. It's not a dramatic change between genders, but there may be slightly higher prevalence in women, and we don't fully understand why that is. Idiopathic hypersomnia, we really don't understand the pathophysiology. It's really not quite clear. There's clearly a difference between the long sleepers, the people that sleep 11 hours or more per day, as compared to the normal sleepers. But we really don't fully understand the pathophysiology or what causes these people this drive for excessive sleepiness. So eventually this will be sorted out, but unfortunately there isn't any biomarkers, and there may be a slight female predominance, but it's not very pronounced.
Okay, thank you. I think you probably did answer this, but it is a question that's probably pertinent to many people in the community. What would be your best guesstimate on when the first orexin agonist might be available for IH in the US?
My guess, so as I mentioned, all of these companies are studying idiopathic hypersomnia. Takeda, Alchemies, and Centessa are in the forefront. Um, my guess would be we might see the first one for idiopathic hypersomnia in 2027. I wouldn't anticipate because they're still doing their trials of these
Mm.
Alchemies and Centessa are still in phase two, so they've got quite a ways to go. Alchemy or Takeda's a little further along, but I think it's going to be a while before we see the first one approved for IH. Probably 2027 would be my guess.
That's really helpful. Sort of related, our last question here, despite people with IH not having low levels of orexin, do you think that an orexin agonist medication could really still help people with IH?
Yes. So as I mentioned, the doses for IH as well as type 2 narcolepsy are going to be substantially higher as compared to the people with type 1. We'll have to use doses of at least 4 times higher for IH and type 2 narcolepsy as compared to type 1 narcolepsy. But it does look promising. I mean, some of these compounds are going to be more effective than others, and we'll just have to see how all this plays out. But the initial signal that I've seen personally is very positive. So I think people with IH are gonna, and not everybody with IH is going to respond to these things, but I think there'll be a substantial number of people with IH that do have a good response, and that and this will be one more thing that we can add to our armamentarium of treatment. So and people may need a cocktail of different medications that work in different ways to actually, optimize their treatment and optimize their quality of life.
Yeah, that's right. Thank you. Okay, last question, I promise. So someone has asked today, besides increases in wakefulness, are any of these new medications showing improvements in vigilance?
So yes, there's data. Well, so some of these there's fatigue and excessive sleepiness, and there's also vigilance. So there's really different cognitive effects. So, and these companies that are testing these orexin agonists are very interested in fatigue as well as excessive sleepiness. So, fatigue is mental or physical weariness, typically associated with activity, whereas sleepiness is a propensity to fall asleep. And cognition is measured differently with different scales. So, but all of these things are being evaluated with these orexin agonists as well as some of these other compounds I mentioned. So, uh, for example, Sanofi has good data that they've shown effectiveness, or at least a signal that people with excessive sleepiness associated with sleep apnea and some degree of mild cognitive impairment have significant improvement with solriamfetol or Sanofi. So all of these compounds are going to be evaluated for the effect on cognition as well as vigilance.
Yeah. So helpful, extremely dense, informative information. I'm glad to say that we are recording this presentation so that we can go back and listen to it again and make it accessible for people, obviously, to listen again, but those that weren't able to join us today. So thank you, Dr. Korsner, for all you do. Truly moving things forward for our community, and we're really grateful for you giving up your time today and sharing your expertise with us all. So thank you.
Thank you.
Thank you.
Take
Bye
care.
for now. Bye for now.
Bye.